Bismillah ar-Rahman ar-Rahim. My name is Fatimah Zaki sakhin, batch 12. My advanced educational seminar topic is what are the techniques that provide pain-free local analgesia for children? First of all, special thanks to Dr. Hana Al-Busaili for her support and cooperation. Outline. Starting with the introduction, dental treatment of children requires successful management of anxiety and pain in order to have a cooperative child who in the course of time will grow up with positive experiences of dental treatment. In adult studies, a strong correlation has been established between dental anxiety and negative dental experiences in childhood. Thus, dental practitioners should always keep in mind that beyond providing treatment for children, their responsibilities is also to influence a generation with positive attitude toward dental health. Management of anxiety and pain in children. The spectrum of anxiety and pain control start with behavior management techniques, which are prerequisites for all types of treatment in children regardless of any basic intervention, for example, examination, prophylaxis. Behavior management techniques, along with appropriate communication between the child and the clinician, ensure a reduction in the level of child's anxiety. Behavior management techniques are strategies of behavior therapy that are modified for dental setting, apart from psychodynamic and humanistic therapies. Contemporary approaches for pain-free local anesthesia. In recent years, researchers have been encouraged to use contemporary approaches as an adjunctive approach to the conventional approaches. Therefore, in results, conduct a pain-free local anesthesia. Encouraging perceived control on children. Perceived control in the dental environment for a pain-free local anesthesia is an objective control of a freedom given to the child, whereby the child can stop the clinician at any time he or she feels discomfort or pain. However, this freedom should be allowed for negative and positive stimuli, and the child should encouraged frequently to inform the clinician wherever she or he has something to tell, feels tired of keeping their mouth open, needs a short break for the water closet or the toilet, feels a bad taste in the mouth, feels any discomfort or pain. Children may overuse this freedom to stop the dentist until they learn to trust the practitioner, who at the all times must be ready to respond quickly when it's used. A signaling device, motor signaling such as lifting a hand or vocal signaling such as saying can be used in the perceived control technique. The clinician should periodically remind the child about this freedom. If you want me to stop for any reason, you can say or okay. Developing self-efficacy skill in children. At the first appointment, both child and family worry whether the child will cope with the dental treatment or not. It is important to alleviate their worry for success promptly, which in turn gradually develop self-efficacy and ensure success in the future sessions. In the dental environment, with its related characters, instruments, and medication, clothing shapes and odors should be presented to the child. The child should also receive a constant reinforces such as verbal, vocal, and nonverbal appreciation in every successful step of the sessions to promote improvement and cooperative behavior such as I am very impressed by how wide you can open your mouth, or to the parents, I do appreciate your child helping me like this. Atmosphere of success should be created as soon as possible in the presence of parents. After the application of topical analgesics, the syringe should be introduced. At this stage, no need for real injection. The syringe can be put into the child's mouth first with its cap in place, thus allowing the child to become familiar with the device. The operator can also address the parents with wow, dear, dear daddy and mommy, can you see how healthy your child is? Like frozen, congratulations, in order to increase self esteem and also to distract. Once the tooth has already been put to a pre sleep or short sleep successfully by using topical analgesics, the child should receive social reinforcers prized with words, touching on the shoulders, and the session can finish with material reinforcers such as stickers, small toys. Strategies for preventing fear of needle. First, non-negative conditioning. The puncturing in an anesthetized tissue will produce a painful reaction. The tissue has to be anesthetized first with topical analgesics. Never administer an injection without first applying topical analgesia. Second, step-by-step approaches. Don't provide an injection at the first appointment and always start with the most comfortable site. For example, posterior maxillary buccal infiltration. Analgesics pathway, pain-free injection might sound strange, but with appropriate use of topical analgesics and a slow patient injection technique, a pain-free injection can be established. During injection, start with puncture of the tissue using fine needles. Then deposition of the analgesic solution should be as slow as possible using a low pressure injection. Then advancement of the needle, which are the physiological components that give pain to the patient. This strategy should be to slowly inject a small amount, 1 to 2 drops, wait for a while, and then advance the needle slightly further and slowly inject another 1 to 2 drops and slightly advance the needle again. Pain-free techniques. Successful techniques depend on the important steps. First, anxiety control. Second, selection of proper material and equipment. Third, dehydration of the tissue by air spray or cotton to allow better absorption of the topical analgesic solution. 4. Isolation of the tissue with the cotton rolls to prevent any leakage of the topical or local analgesic solution with a bad taste. 5. Application of topical analgesics for a minimum duration of 2 minutes. 6. Injection by creating an analgesics bath. Some sites in the mouth are easier and more comfortable for patient, thereby permitting a better first local anesthesia experience for child. Whenever possible, local anesthesia experience should start with the most comfortable sites, which is generally accepted as the posterior maxillary buccal region followed by mandibular buccal or labial regions. Palatal, lingual, and mandibular block injection have been found to be the most uncomfortable and therefore should not be the injection of children first experience. For lingual and palatal injections, indirect approaches via interdental papilla following the analgesics pathway will give a more comfortable injections for most children. Further developments for pain-free local anesthesia, the type of syringe is important because each has a different characteristics which has implications for both the operator and the child patient. A syringe should have ergonomic designs for easy of injection and aspiration and provide a good sense of control for the operator. It should allow slow and low pressured injection. First, computer-controlled local anesthesia delivery systems. In 1997, the wand was the first to introduce such a system into the dentistry. Advantages: provide controlled delivery of local anesthesia solution at a constant and different speeds, allowing minimizing of pressure to the tissue. Allow painless anesthetizing of areas of mouth. The lightweight handpiece is more tactile and allows better manipulation. Disadvantage of this device is the high cost. Second device is the jet injectors or needleless syringe. Needleless character make jet injectors a superior and attractive to other syringe, provided by jetting under high compressive forces instead of needle insertion. It has valuable alternative in pediatric dentistry Again, the disadvantage is the high cost, possible post-injection wounds, high sound level, and unpleasant taste. Third, intraligamentary injection, PDL injection, is administered into the healthy periodontal ligaments with a syringe specially designed. It prevents the numbness of the soft tissue and the rapid onset, less traumatic than conventional block. Disadvantage of this device: conflicting data are reported about its use in primary teeth where the permanent tooth bud is present. Eutactic mixture of local anesthetic AMLA is a topical analgesics that contain 2.5% lidocaine and 2.5% bromelain. Reported successes in the medical field and the oral tissues. Disadvantage: the intraoral use of the AMLA cream is still not recommended by the manufacturer as the safe dosing amounts for the mucosal application are not known. Electronic dental analgesia, it is non-pharmacological method of pain control. It is called also electroanalgesia or transcutaneous electrical nerve stimulation. The mechanism of action is based on the gate control theory. It has successful results in the pediatric dentistry. However, lack of interest among most clinicians and companies for marketing the electronic dental analgesia for dentistry. Intraosseous injection, delivery of local analgesic solution directly to the cancellous bone adjacent to the tooth to be anesthetized, is performed in 3 steps: mucosal analgesia, perforation, and injection into the cancellous bone. It's provided analgesia for 1 or 2 teeth without lip, tongue, cheek numbness. Disadvantage: requires special device, lower success rate in inflamed tissue, risk damaging permanent teeth germs, and require informed consent. Hope message: creating a strong connection on the child's first visit helps to create a comfortable atmosphere in which the child does not feel threatened. Therefore, it is important for the dentist to establish a friendly relationship with the children in order to combat patients' fears and to deliver effective and efficient treatment. References. Thank you for listening.